Hi, everyone. I'm Erin O'Malley. I'm the Program and Outreach Coordinator at Northwestern Medicine Living Well Cancer Resources. I'm so happy to welcome you guys to tonight's special medical presentation featuring our own Dr. Christopher George, who is the Medical Director of Medical Oncology at Northwestern Medicine. Just a little reminder, if you have any questions during the presentation, to just drop them in the chat below and we'll get to them. We really do appreciate you guys coming out tonight virtually, and I will hand it over now to Dr. George.
The topic of tonight's talk is about survivorship. And I'll tell you, when you talk about how we are trained to be cancer doctors and oncologists, I trained about 25 years ago at the University of Chicago, and they trained us to look at cancer as a journey that begins when cancer is detected, either because it comes to light and makes people sick or through a screening test. And then the cancer, we try to determine the extent of it. That's called staging and diagnosis. That's the part of the journey where we do scans and see how advanced the cancer is. And then there was treatment. And I'd say, as a medical oncologist, 90% of my training revolved around treatment: when to use surgery, when to use chemotherapy, what sort of chemotherapy to use. That was definitely the focus. And that last column there, the survivorship and surveillance part of a cancer patient's journey, was almost ignored, is probably too strong a word, but it certainly was neglected. We just didn't pay attention to it. And when a patient finished their treatment, we sort of washed our hands and gave the patient a high five and sent them on their way. And I think what we've learned over the last 10, 20 years, is that that's not right. That patients who've completed treatment still have a lot of needs. They have a lot of questions. They have a lot of issues that need to be addressed. And the good thing is we have a lot of tools to address those needs. And that's what we're going to talk about tonight. How can we help people be cancer free, stay cancer free, and how can we help them be more healthy than they were to begin with? When we talk about this after treatment period, survivorship is what we call it. What are we trying to do during that period? Well, we want our patient to heal. As I'm sure a lot of you on the call know, cancer treatment's hard. It puts a lot of stress on people: emotional stress, physical stress. There's lots of toxicity. You need to recover from that. It wears you down, and people need to recover from that period of intense treatment. We want all our patients to be very knowledgeable. So we want to educate patients on what they have, what they've been through, so that they understand later on, because it could come to light later. Their toxicities could linger. You could see a different doctor, and it's very helpful to know what you've been through, what stage cancer you had, and so forth. And then the two words I've underlined in this slide: we want to monitor patients for relapse. We call that surveillance. And we really want patients to be healthy. So if there was any lifestyle issues that led to the cancer diagnosis to begin with, how can we address those and help patients stay cancer free long term? So dividing that up, probably the first question I get when a patient has completed cancer therapy is, when will I feel better? Cancer treatment is really, really hard. And just because cancer treatment stopped on Friday doesn't mean you're going to be feeling 100% by Monday. It takes a while to recover from that. Different symptoms take different periods of time to recover from. The fatigue of cancer treatment can definitely linger. Neuropathy is that feeling of numbness and tingling. It's often in the hands and feet, but it can be other places that can linger. Many of you have probably heard the term chemo brain, which is just not feeling dialed in and sharp when you're on cancer treatment or post-cancer treatment. Patients want to know when their immune system will recover from cancer treatment. When can they go out and be around people? When can they be around young children with runny noses and so forth? These are all questions that are important. The anxiety and stress, I think what we've recognized over the past couple decades, patients are really torn up from cancer treatment. Some of them really have PTSD, post-traumatic stress. It can really be a big deal. And we have tools to address this, so we need to recognize them so that patients can get the help they need. talking about knowledgeable, making patients knowledgeable and understanding what they've been through. Um, you would be shocked how many people I meet who had cancer 10 years ago or 15 years ago, and they don't know what stage their cancer was. Some people don't know what kind of cancer it was. You know, when you say skin cancer, there's different kinds, and people don't know what kind they had. Cancers of the brain, there's multiple different kinds. We want to make sure that our patients understand all that. Um, uh, when I went through training, the number of chemotherapy drugs was really limited. You know, when we talk about chemotherapy now, there's thousands of different chemotherapy drugs, literally. Um, you are not expected to remember all this stuff. Nobody can. Ask for a summary. Ask for a summary from your doctor of what you've been through and so forth. In summary and follow-up care, you really should ask for a written summary of everything you've been through. Like I said, nobody can remember every drug that they had. They can't remember the dates. They can't remember the doctor's name. Um, that's really standard. You are not going to be able to keep that straight unless you get a written summary. Your doctors, your providers should be very willing and very able to provide this. Different systems, different health systems, different clinics do this differently. What I'm going to show you in the next couple slides is what I do in my clinic and what Northwestern Medicine does. This is a written summary, and like I said, they all look a little bit different, but the information that you need, you should know your medical team. You know, if you stop seeing your surgeon for 3 or 4 or 5 years, you're going to forget who that person was. You need that written down, and we should provide that. You should know your cancer diagnosis information, like the date. You should know the stage that you had. If I'm talking to any cancer patients right now on the call, if you don't know what stage your cancer was, be sure and ask. And if you don't know what cancer stage it was, I would emphasize that that is not your fault. That's our fault. That's the doctor's fault. If my patients don't know what stage they had, that's on me. I should let them know. I should educate them. And some of that information is written in jargon, like you can see at the bottom of this slide, where it says tumor type and histology and so forth. That is written more for a future physician to understand what happened, but we can translate that. We can certainly put that into layman's terms so that it's very clear. In this case, this is bladder cancer. This is a timeline of what you've been through. And again, nobody has this memorized, but this tells the future physicians what the diagnosis was, in this case, bladder cancer. In the first sentence here, it says high-grade papillary urothelial cancer. That's written for a future doctor. That means bladder cancer. A little bit lower in the paragraph where that you can see it says MVAC, that tells physicians what chemotherapy agents were given. And then really important is the surgery. Cystoprostatectomy in this particular example means that the bladder and the prostate was surgically removed, and the stage T2N0. Um, again, what we should do is synthesize your medical record. If you request your medical record, if you've ever done this, you know, when it's written out, you have a stack of paper that's, 6 inches high on your desk. We should summarize that so that it's a really nice, concise story of what the patient's been through. So this is really important. This is talking about surveillance. So when we put someone through cancer treatment, how do we know it worked? Well, sometimes we don't know whether it worked. We need to follow the patient to be sure that the cancer never comes back. And every single cancer survivor has a follow-up schedule, and it's all different. Sometimes there's flexibility, sometimes it's very rigid. This is an example that I have in this slide of this same bladder cancer patient. And what this is telling you is that early in their survivorship, at year 1, at year 2, we're going to see the patient every 3 to 6 months. We're going to draw blood and check urine studies every 3 to 6 months. And then what sorts of scans are we going to do? In this case, we're going to do CT scans, and we're going to be pretty intense the first 2 years because that's when the chance of cancer recurrence is the highest. And then as a patient gets further out from treatment, we start to widen the interval between visits. Every cancer will have its own cadence. It'll have its own schedule. So there's no point anyone copying down what's on this slide. It wouldn't apply to you. Someone who had breast cancer is going to be different than someone who had leukemia or lymphoma. It's different for everybody. This talks a little bit more about that. How do we monitor for cancer recurrence? And again, this is individualized. It depends on what sort of cancer you had. It depends on what stage you had. But in general, after cancer treatment, you're going to see the physician periodically. Sometimes that's every month, sometimes it's every 6 months, different for everybody. Right here, when it says labs, that usually means blood tests, sometimes urine or other tests, but usually blood. And then scans, which is imaging. For some cancers, a PET scan is the right scan to do. For some cancers, it's a CT scan, and from others, it's an MRI. So that can be different depending on your diagnosis, but oftentimes there's a scan involved. Not every cancer is followed with scans, but a lot of them are, for sure. Besides the scans in the labs, there are procedures for some cancers. Colonoscopy is a great example. If you've had colorectal cancer, you'll be followed with a colonoscopy. Scans are not adequate for that. And then the last bullet point here, when I've said tumor markers, these are blood tests that can help us detect certain types of cancers. The most, I think, well-known and widely used tumor marker is PSA for prostate cancer. Some of you might be familiar with that. It's a blood test that gives us a sense of whether prostate cancer is active or inactive. So why is it important to catch recurrences? I'm going to show you a couple scans. What you're looking at on this slide is a CT scan. This is what we look at when we order a CT scan, and it's a cross section of a person's body. This big white section of the CT scan is a patient's liver, and you can see how it's kind of light gray. The whole liver is a light gray color, pretty heterogeneous. There's not a lot of variation across the organ. What the arrows are pointing to of two spots within the liver that are darker gray. And on this particular scan, what those dark gray spots represent is recurrent cancer. And it's important. This is a success story in this particular example because catching these spots means that we can do surgery and we can cut out this recurrence in the operating room and render this patient cancer free. That's a great example of why we want to follow cancer patients and cancer survivors closely so that if there is a recurrence, we catch it early enough to where a patient has more options. It's important to emphasize not every patient, like I said, not every cancer is best followed with a CT scan. Certain cancers have other scans that are more appropriate and just better. I think communication is critical. I hear from a lot of patients. This is a major patient, I would say, dissatisfier, where it's frustrating to patients where the doctors aren't talking to one another, where they're not functioning as a team, and it's critical in cancer because the days when cancer patients were treated by a single physician are really over. Um, uh, these days, if you have cancer, you are managed by more than one physician. It can be a medical oncologist like I am. A surgeon is often involved. A oncologist who delivers radiation. All these providers. A single patient can easily have three different oncologic specialties on the case. Not to mention other providers like the primary care physician. If you've got heart disease, we need a cardiologist. If you've got diabetes, we need an endocrinologist. So these teams can be quite big. And it's not just physicians. We need a physical therapist, a dietitian, a social worker, a geneticist, nurses, advanced practice providers, APNs, nurse practitioners. All these people need to come together. And oftentimes they're not all at one location. I think patients should expect their team to communicate with one another. And these days, when we have electronic medical records, it's easier than it's ever been. I won't say that the electronic medical record is perfect. There's some things about it that I don't like, but man, it's made it easy for me to talk to physicians at other sites. These days, I can co-manage my patients with providers out of state, and it's never been easier to do that. So if that's not happening, I really urge you as a patient to demand that. because it is easy and it is really important. How do we communicate? Well, we do it through the electronic medical record frequently. And I don't know if I say the word tumor board, if that resonates with you. But a tumor board is where all the providers get together. And what this is showing you, the photograph on the left is what tumor boards used to look like, where there were providers in a single room talking to one another. Up on the screens, we'd have scan results, we'd have biopsy results. Um, that's really old school. After the pandemic, tumor boards are starting to look a lot more like this lecture tonight, where the team, the doctors, the providers talk to each other this way through Zoom or through Teams. And I'm not sure we'll ever go back, frankly. Just as talking to patients, I don't know if we'll ever do lectures in person anymore. It's just gotten to be so convenient to do these things on Teams. That's the way boards look now, which is the photograph on the right, where the providers are all talking to each other electronically. I kind of think the electronic method is a little bit better. We tend to get better attendance, we get better discussion. It's nice. It's a good thing. Um, so if you have finished cancer treatment, we hope that the cancer's controlled, at least, if not better yet, it's gone. And you can talk about your cancer in the past tense. You can use the word cancer survivor instead of cancer patient. That's what we want you to be after you finish cancer treatment. Um, we want our patients to stay that way. So how can you, once you become cancer free, how can you remain cancer free? And there's, I think, some common sense things that you can do to impact your lifestyle to remain cancer free. If you ever use tobacco products, whether it's chewing tobacco or smoking or using a pipe or whatever, don't do it. Um, we are learning more and more about the link between obesity, type 2 diabetes, poor metabolic health, and cancer. So if you can, please maintain a healthy body weight. I'll talk a little bit more about diet and exercise later in the talk. Um, if you can do those things, you can reduce your chance of having cancer and cancer recurrence. Depends on what source you look at, but I think 30-40% is a realistic estimate. Um, the more we study alcohol, I think the more that we realize that there really is no safe level of alcohol use. Alcohol is probably bad. Different doctors will tell their patients different things. I believe in moderation, but I certainly have colleagues who believe that they believe in alcohol abstinence. We should stop it, period. Physical activity, I think of all the things that can help people recover from cancer treatment, physical activity, exercise, physical therapy is probably the least utilized. It is so important to be active, and physical activity can help you get better faster. It can help your energy can come back quicker. It can treat fatigue. It can treat balance issues. It can treat weakness. It can treat depression, anxiety, all those things. Over and over and over again, physical activity has been shown to help people feel better. Um, and I would say, and I'm guilty of this, in my system, in our cancer center, we don't refer patients to physical therapy and exercise programs enough. It's better than any pill for a lot of situations. It's better than any pill. It's just absolutely fantastic. Um, it can improve your endurance. It can help with balance. So many things. Um, if you have not been offered physical therapy after cancer treatment and you're still feeling low, you're still feeling fatigued, you're not productive, please bring that up with your physician. This slide tells some resources for patients who are struggling to get active again. We like to recommend 30 minutes of moderate, vigorous exercise 5 days a week. That's difficult for patients that are fresh out of cancer treatment. Don't expect that you're going to be able to do this the day after cancer treatment's done. Sometimes you have to work up to this. If you can't do this, we have fitness centers, we have exercise therapists, we have physical therapists, we have Marion Joy rehab facility. All these resources are available to patients, and we need to have a conversation about which one is right for a specific individual. Living Well, who is, sponsored this talk tonight and is helping me put this on. They're an excellent resource, just the best. If you want to be more active and you're having trouble figuring it out and trying to understand, um, uh, the best approach to that for you as an individual, please start with Living Well. We have an absolutely fantastic resource that me as a physician, I'm so lucky to have Erin Bloodworth, whose contact information is on this slide. Um, she is an exercise therapy consultant, and she can work with you. You can tell her your story. She can look at your records. She can figure out what you need, and she can come up with a program that is specific for you. And maybe you are somebody who should sign up for a 5K. On the other hand, maybe you're somebody who should start with some um, chair yoga or meditation or low impact walking every day. She is going to be able to talk about you specifically and what's the best program for you. If you would like to be more active and you're struggling with fatigue, please do not resign yourself that that's your new normal without contacting Living Well and seeing if there's something there for you specifically. I have many, many patients who, I'll offer some sort of physical activity program, rehab, or physical therapy. And many patients will say, I'll do it on my own. Studies have shown over and over again um, that patients who try to do it on their own are not as successful as patients who get into a program, who get into some sort of regimented way, who have some sort of a coach, a therapist, somebody who's working with them. I really, man, if you can do it on your own, hats off. That's great, and that's amazing. Um, but if you fail, if you're struggling to do it on your own, you're not alone. In fact, you're very normal. Um, I would encourage you, if you're struggling with this, to ask to get on a program, and your doctor can help you with that. Living Well can help you with that, and we can look at all these different resources, whether it's Living Well, the Aaron Bloodworth that I just mentioned, or whether it's Marion Joy Physical Therapy Center. All these places are available to you, and you will be more likely to be successful with some professional help. So what is the right diet for a cancer survivor? And I'm a believer, and this is I'm giving you my opinion right now. My opinion is that there is no single diet. I think each individual patient needs to find the diet that works for them. So I don't think every cancer should survivor should be a vegetarian. I don't think every cancer survivor should go on the keto diet or the anti-inflammatory diet. What I believe is each cancer survivor or someone living with cancer needs to find the diet that works for them specifically. I don't think one size fits all. If you get on Google after this talk and you Google cancer prevention paleo diet or cancer prevention vegan diet, you're going to find somebody on the internet who's going to say, yes, vegan diet is what you should do, or yes, antioxidant diet is what you should do. I think you have to find the one that works for you. Now, how do you know which diet works for you? Well, a few things. One, it has to be a diet that you can actually do. Um, if you're on a diet and you just can't make it work because it's a raw vegan diet or the paleo diet, if you can't adhere to it, then I don't think it's worth fooling with. Find a diet you can adhere to. I think you should find a diet that keeps you at your ideal body weight, and that's not. I don't think that's the same diet for everybody. For some people, it's intermittent fasting. For some people, it's like I said, vegetarian. You got to find that out. I think if you have diabetes or obesity, you have to find the diet that helps you control those things. High cholesterol, find the diet that helps you control those things. And again, I think this is a journey. I tell our dietitians and our nutrition consultants at Living Well and Northwestern, I really tell them try to meet the patient where they are. If they can't if they can't become a vegetarian, don't try to push them. Find something else. Find something else that's going to work for the patient. And I think that's really critical. I'm gonna tell you guys, If you like the answer I just gave you, if you like what I just said, don't ask anybody else because you're going to get a lot of different answers to this question. I have colleagues who do believe that there's one single diet for every cancer survivor, and they're going to tell people that. But I am of the opinion that you have to find the one that works for you. Uncontrolled diabetes is bad. The connection between sugar and cancer, it's very real. I mean, I get that question a lot. I'll bet some of you on the call tonight have heard this, that eating sugar feeds the cancer, or high sugar diet feeds the cancer. I think that that's an oversimplification, frankly. I think the relationship between sugar and cancer is very complex, and I'm not sure that scientists fully understand it yet. There's tons of research going on about this, but we know that people with high sugars, diabetics, for example, their cancer outcomes are not as good. We know that people who are morbidly obese, their cancer outcomes are not as good. I think it all goes back to metabolic health. And if you can improve your metabolic health, I think you'll improve your cancer outcomes. And that can be sugar, that can also be cholesterol and fats and so forth. And I think there's a huge connection between a high BMI, body mass index, a connection between being above your ideal body weight, um, and poor cancer outcomes, more cancer cases. I mean, there's definitely a connection, and I don't think we fully understand why that is. Um, People who are above their ideal body weight, they're less healthy for a lot of reasons, but it does seem as though they have more aggressive cancers, harder to treat cancers, and their cancer outcomes are less good. So if you can control these metabolic markers of health during cancer treatment, or more importantly, as a cancer survivor, I think you will increase your chances of having a good outcome, meaning cure, or meaning long-term control. Genetics, I think I only have one slide about genetics, but this is something. When I meet somebody who's been diagnosed with cancer, we definitely talk about family history. Did your parents have cancer? Do you have brothers and sisters with cancer? Do you have kids with cancer? It's super important. And then, when patients are just diagnosed, we sort of move on really quickly. We take that family history and then we get into, how advanced is the cancer? Do you need surgery? What sort of treatment plan do we have? And sometimes to be really honest with you, we kind of forget about the genetic component. After cancer therapy, that's a great time to revisit genetics, talk about that family history again, see if there's any reason to suspect that somebody was born with certain genes or chromosomes that might increase their risk of cancer. As we learn more about the DNA of tumors and the DNA that people were born with, we're finding out that we can individualize treatment. We can target certain genes. So this becomes really super important, more important than it's ever been. It doesn't just affect a cancer patient's children. It affects how we treat that cancer patient specifically. You can look at how many cancers have a genetic component. Again, I'm calling out breast, prostate, and colon cancer because they're common, and they have been shown to have a pretty reproducible genetic component. So we see that quite a bit. We see patients with these cancers who were born with a gene that predisposed to cancer. Um, and it's definitely worth looking for. It's really important. If we haven't had time to discuss the genetic components of cancer during cancer treatment, again, during survivorship, it's a great time to revisit. So I'm coming to the end of my talk, and there's some things that we didn't get into that are really important for cancer survivors. Again, psychosocial well-being. Um, Cancer can be absolutely life-changing. Even when you're done with treatment, even as you go into that surveillance phase, the scars, whether they're emotional scars, psychological scars, or physical scars of the cancer treatment, they're very real. And recovering from that, coming to closure with that can be a journey that we should address as your treating team. Financial well-being, I hate that we have to talk about this, but the treatment of cancer is becoming just absolutely ungodly expensive. It's crazy. I as a cancer doctor, I'm routinely prescribing medicines that can control cancer. I do a lot of prostate cancer. And the drugs that control prostate cancer can cost $10,000 to $15,000 per month, which I think is crazy, absolutely crazy. I'm kind of embarrassed about that. As an American doctor, we need to address that with patients. We need to talk about their physical well-being. We need to involve philanthropy? Do we need to approach drug companies and ask for assistance? These are things that as a doctor, my team can help patients with. Fertility is a really big deal for a lot of patients. We have a lot of cancer patients who are just starting out in life, and they haven't had children but want to have children, or they have children and want to have more. We need to talk about that. Is cancer treatment going to affect their ability to have children in the future? See, it's a big deal. Parenthood, whether you have children, young kids, or whether you have adult kids, how do you talk to your family? How do you talk to your children about cancer? Um, we can try to help you with that. Not every family has the same dynamics. Obviously, we have to tailor this, but we'd like to help people understand how to involve their family in their cancer treatment. And then the last bullet on this slide, sexuality and intimacy. Um, Cancer treatment can really affect this, and sexuality is an important part of people's lives. A lot of cancer survivors, they kind of they're private people. They don't want to bring this up. No one should be embarrassed, but I think some people are, or they're maybe embarrassed is the wrong word, but they're not comfortable talking about this. If that's you, if you're on the call tonight and you're not comfortable talking about intimacy with your doctor, bring it up so that we can get you to somebody where you are comfortable talking about it, because there are resources to help with this. I I am not a physician that tells my patients to stay off the internet. Um, I really I want my patients to be educated. I want them to, you know, learn to talk to people, to be knowledgeable about their cancer and ask questions. Uh, I think what you have to do is you have to be discerning when you get on the internet. There's a lot of absolutely great stuff on the internet. Very good, educational, really good resources, really good information. You just have to find those places and sift through the garbage. I mean, there's a lot of really bad places on the internet too, and it can be really hard to tell if you read something on the internet that says, "Gosh, I don't know, uh, coffee enemas treat cancer." Or whatever. Sometimes you can't tell whether that's a good source or whether it's a bad source. Print it out, bring it to your treatment, bring it to your doctor and say, "Hey, I read this on the internet. What do you think?" I like that. I like my patients to do that. What I have on this slide and the next three slides is websites that I think are reputable. These are websites where I would direct my patients, and I think the information you're going to read in these places is really good. This is not exhaustive. There's other places that are equally good. And we'll give you a copy of these if that's helpful. And so you don't need to write all these down. But these are places where I would refer patients and say, if I spend 10 minutes with you and you haven't really gone into the depth that you'd like to go to, these are places where you might get more information and come up with some topics and questions that we can talk about at the next visit. Well, I so appreciate everyone taking time out tonight. I always learn stuff when I give this talk. So thank you for interacting.